So let me show you the outline of this program. First, I want to speak about HepatoCarcinoma, simplified because I don't know that is a number of physicians in this room. So I'll give you some epidemiological, natural history and diagnosis, and the treatment. After, I want to show you a result of ethnographic study for the APN roles of the management of the HCC patient, and we conclude. So, like you know, the HCC
excuse me,
is
would you make the microphone close to your mouth? Thank you. Just make it closer. Yeah.
Closer.
Yeah.
Liver cancer is the 6th most common cancer in the world, and its mortality is very, very high. It's also the most common primary liver malignancy in the adult. The increased incidence in the world is very, very high. Now in France we have 9,000 new cases in 2012. The mortality of this cancer is due to the late diagnosis and the underlying disease. So the natural history of the HCC is first on the cirrhosis and is due to viral hepatitis like VHB and VHC, alcohol, and recently with the increases of the Nathalie. We know that in the world, all the risk factors are different. In Europe and in North America is a VHC. In Asia and Africa is a VHB. But in Japan, it's also a VHC. So the treatment are probably different in geographical variation. Which patient was screened for detection of the HCC? In recently a recommendation, all the patients with cirrhotic due to HCC, HBV, or alcohol must be screening for the HCC. The recommendation is to make an ultrasound every 6 months with alpha serum, alpha fetoprotein dosage, but it's not really make. The tumor, like you know, is here. The diagnostic of HCC is non-invasive exam, but the diagnostic is according to tumor size. You know, if you have a tumor more than 2 centimeters, and if you have cirrhosis, and if the CT scan MRI show you an hypervascularization on the arterial phase and a washout, you can say that you have a HCC. Here you have a nodule with a hypervascular nodule, and here the same nodule with a washout. Here you can see that you have an HCC. But if you have a tumor less than 1 centimeter, you must be a surveillance. If you have a tumor between 1 centimeter and 2 centimeters, you must have 2 radiological exams, or if it's atypical radiological, you must make a biopsy. So, the treatment option for the HCC. We have some limitation with the size of the lesion, but you have an underlying disease, and you have the location of the lesion. Let me show the treatment for the HCC. The best treatment is the liver transplantation, because you put up the liver and the tumor. Which patient? This patient must have 3 tumors less than 3 centimeters or 1 tumor less than 5 centimeters. The survival of this treatment is 7% at 10 years. The chirurgical liver resection is a local treatment, but is also a curative treatment. We must have one tumor less than 5 centimeters, and the child-proof are with portal hypertension. The survival is 30% at 5 years. A local percutaneous ablation is like a chirurgical patient and like the same survival. Now we have a palliative treatment. The TAS, for which patient, this patient must have multiple tumors, but no metastases. The survival is 40% at 3 years. And we have also a palliative treatment, a systemic treatment, angiography, for which multiple tumor, metastases, not eligible for the chirurgical treatment or liver transplantation, and child-proof A. The median survival is 11 months only. So the treatment is very complex, and we make some physician, surgeon, radiologist, oncologist. I want to show you now the roles of the APN, of the nursing practice advantage. In France, it's difficult because we have lowered and we have not established really this role. So we decided to make a study, and because the impedance physician shortage and the rising increases of liver disease make that it's now real that to have a nurse in this system. The aim of the study is to explore the new roles of this nurse, especially in this department. So the study method is an ethnographic method because is a only qualitative study to make an exploration on the ground. So you have shown that we have to manage the patient, the cirrhosis of the patient, and the tumor. You have known also that we can have a curative treatment and a palliative treatment, and you must switch to curative treatment for palliative treatment really, really quickly if we have not a real management of this patient. So, the role of APN and the quality of APN. Here is the patient with a comorbidity. We have an increase of age. We have an increase of the cirrhosis management. We have the tumor, must be all detected. And we have some physician. So, the nurse is really an orchestra chief. In our department, you make a weekly multidisciplinary HSC meeting with all the actors, hepatologist, surgeon, liver transplantation, radiologist, oncologist, nurse, and research nurse. She make a discussion, and she give a better treatment for the patient. The skill of the nurse. Before the weekly meeting, she updated medical records, imaging, biology, anti-recurrent events, concomitant treatment, and after the weekly meeting, she tried to decrease the delay before the treatment, and she organized the treatment, and she made the relationship with the primary doctor. When we take the treatment, before the treatment, the nurse make a consultation perhaps with the doctor, and only and she can make this consultation alone. She updated the medical record again, and she updated the concomitant treatment. So she make an organization to follow up, and she was the primary health care for the patient when he go back to the home. For example, for the anti-angiogenic adverse event, the nurse can make a good primary care to make some recommendation for the foot and syndrome. She can make a reassurance for the patient. For the diarrhea, she can say the regime, and for the hypertension, she can give to the patient some details for the treatment. In the follow-up, the nurse makes a coordination, and she makes also an expertise. She organizes the follow-up in accordance for the guidelines, and she looks if it's necessary to make a new weekly meeting for this patient. She manages the comorbidity and the specific population, elderly patient and viral co-infection. She managed the symptom of the HCC and the liver disease, and she managed the symptom of the treatment of HCC. So the coordination and the expertise of the nurse make for the patient some acceptance, a better adherence to the follow-up, not especially for the treatment, but also for the follow-up. And she can give for the patient a better quality of life. So with this study, we have realized that the nurse is, by her availability, she makes a better quality of life. She manages patient in her globality. With the empathy, she could make a role between physician and the treatment and the patient and her family. With the expertise, the patient must question, and they don't come in the hospital by the emergency or a new consultation. And for their organization, she make a screening and a follow-up like better for the patient. So the perspective for this new job in France is mainly to make a cost effectiveness for the duration of the hospitalization, a better access to the care, and she can make also a satisfaction and information for the patient. All qualitative studies are based on the satisfaction, and some studies make a difference for the cost effectiveness. And the nurse can optimize the adherence and the treatment for the patient. Thank you for your attention.